Hello and welcome in today's nursing webinar session. Myself, Shanti Bhattacharya, the VP Nursing, and we are going to talk about the most challengeable, the brain teaser topic, which is nothing but end of life palliative care. And let me welcome the two of our very marvelous speaker, panel expertise. None other Dr. Bharat Vasawani ji, who is our senior consultant medical oncologist and hematologist from Yashoda Secunderabad unit, and the charismatic Dr. Pragya Rashmi, who is our senior consultant psychologist from Secunderabad unit. So we are going to talk about the end of life. Last year also we did have this session, but this time we are going to talk about a lot of psychosocial and psychological and medical aspects of this. So as we all know, the concept of WH, the UL has been defined that in UL for end of life patients, we are trying to provide the comfort, nothing else. And the palliative care is a resource where the quality of life is being productively given to the patient, not only to the patient. Bharat sir, can you just unmute yourself? Yes. Not only quality of care we are providing to the patient, also trying to alleviate the suffering of the patient relatives as well. So first question I would like to quote to Dr. Bharat ji, ki what is the current status of palliative care, how far we have come? So sir, we would like to have your insight.
Now, as a cancer specialist, the most important aspect in our treatment is palliative care. Unfortunately, speaking about palliative care, if you look into the statistics or the data, less than 2% of the population probably have access to a proper palliative care.
Yes.
There are many reasons to it. Probably this concept of palliative care, although started at around 25 years back, probably over a period of time, slowly we are recognizing, or what I can say, it is evolving concept.
Yes.
Saying this, probably in our Telangana, we are slightly ahead of our counterparts in other parts of the country, that this concept of palliative care has started picking up well. But again, saying this, we need to go a long way where I can say that this palliative care is available for all our cancer.
So here, all the time, all the more, these paradigm of clinical trials are also connected emotionally as well. So my, question to Dr. Pragya Garu is, how does one cope with the psychological effects when the patient goes for is declared as a UL?
See, we come from a country, we come from a culture where we don't believe in putting out things that are unpleasant, right? So culturally, as Asians, we don't like doing that. So the moment somebody talks about end of life, it is like we are saying something negative. So we don't want to talk about it. We only want to talk about things that are positive. It is almost seen as a failure, right? It is seen as something that could not be done. So therefore, this paradigm of thought needs to change, and which is what palliative care does, which is what where senior people in oncology are coming in, and where we are telling the patient that, listen, it's not a failure, you still have life left. Palliative care, while we are saying end of life, it is actually remaining years of your life. So the term that I always prefer is, instead of end of life, if we call it remaining life. So remaining life is way more positive. So we are not talking about the journey from today to death, we are talking about how to make that pleasant. So the moment we change the paradigm, the acceptance level also obviously changes.
So as you stated very, greatly, that the remaining end of life, which is going to, be little positive factor for the patient and the family members. Thank you. And again, to sir, like I know the patient comes with a lot of frail conditions, disease, as you are the onco expert, and non-onco condition also like cerebral stroke, heart failure as well. So maybe the nursing viewers are also there looking at this webinar, and they may not know what is the difference between end of life and the critical care which they should look after. Like, so when is end of life indicated, sir, and when it is declared in simple terms?
If I have to define a end of life care, probably what Madam said, I fully agree. Now, for those patients who are in the advanced stage of the disease, has no satisfactory disease modifying agent available, very weak, bedridden, poor performance status, poor nutrition, poor feeding, and over a period of time, gradually slowing of the vital parameters
Yes.
like breathing, pulse, continues to have pain, are bedridden. So when we talk about end of life, as unlike palliative care, it is for those patients who are probably progressed beyond all those treatments which can modify our disease and probably are bedridden, and here comes the role of what we say other modalities of treatment
Yes.
to make their life more comfortable.
So, like now, keeping the patient in the centric care, and we always have learned, and now we practice as well, that comfort and dignity to be respected in terms of patient preferences and challenges. So it is going to be more patient centered, decision making process. Now, when we look at autonomy, empowerment, and giving and receiving lot of communication challenges, like in terms of breaking bad news and all. So my question again to sir, to you: what happens when patients are given this freedom of autonomy or decision making in terms of selecting the medical, progress in terms of? I'm sure that must be little.
This is something I think I'll be very truthful to answer this question is in India, the thing autonomy means taking own decision is somewhat lesser when we compare this to our counterparts in Western countries, where
Yes.
it is mandatory for for the doctors to inform patients about the condition of the patient, the prognosis, the option. In India, probably maybe because of maybe a social barrier or something, that's something that autonomy to the patient is given, but not to the way we expect to them. So
Yes.
probably the attenders are someone, the children, the grandchildren, they are the person who take the decision. But if patient were to decide, I think that would become the best part of treating it, because that is the way the person who himself is taking a treatment should be given that option to decide how he wants to take the treatment, what sort of palliative care is good, what sort of treatment he will like to take it. So autonomy will go a long way in probably solving lot of our problems and making patient realize and let patient take the own decision. But unfortunately, if I talk in a country like India, this is something which is lesser as I compare with my Western countries.
Yeah, beautifully described, sir, as you are the one who witnesses all this. And my again question to Dr. Rashmi ji, ki, having spoken about this autonomy and empowerment, as Bharat sir said, ki it has to be again, definitely going into a long way. How does it fosters, the patient benefits from these two, values and principles, if it is to be, done in the UL setup or PC setup?
See, we cannot see this as a standalone event. It is a continuum, first of all, right? So we have to understand it in terms of, first of all, it's like, asking how long does it take to boil a potato. Every potato will boil it at its own pace, depending on the water, depending on the heat and the type of potato. So exactly like that, every palliative care, we cannot have a generic understanding of it. It is unique, because every death, just like every birth, is unique. So we will have, and dignity in dying is a concept that is still foreign, because ours is a community death kind of a culture. So for us, dignity in death and understanding and respecting. Now, here there are two things we must understand. First and foremost, when we are talking about dignity in death or palliative care, what does the person want? We can't be dismissive of the fact that it is a pain. Some of the biggest things that patients come and report is that saying that, oh, they are telling me to be too positive. I can't be positive. To understand, and you talked about nurses, so I will say this, that nurses need to understand that you don't have to be happy. You can be peaceful. It's a difference, right? Be happy, be positive, it's not required. We can just let the person be as they choose to be, whatever their ongoing emotion is, so that they are more accepting of their emotion and take the next emotion. So I think, yes, dismissal of their pain emotional pain is something that we need to look at.
And I know key patient in the PC setup progressing towards the end of life or remaining leftover life. And every day we see clinically the patient is deteriorating. So, and the healthcare professional, how should they handle this communication dynamics, like breaking bad news? I know it is being taken care by the medical administrator and the consultant itself, but even sometimes we see many times patient relatives coming in, walking in. What should be the dynamics that you should tell to the healthcare professional who are bedside?
See, if I have to answer this question, actually sir is a better person to answer this question, because thankfully I don't have to convey the bad news. I have to take it on after the bad news comes, and I'm blessed, because I'm sure that's a tough job to do. And when we do a tough job, we ourselves are very anxious.
Yes.
It is not the patient's anxiety, because 9 out of 10 times the patient knows it. He just hasn't been told, right? It is we who are saying we are in a state, we are, mollycoddling it. They don't like that. So what we have to do is, like my professors used to say, give it to them straight. Simple, straight, easy.
Yes.
That's it. Sir, I think that's the right way, isn't it, sir?
Now,
So
if
again, yes,
I
sir.
just add on it, look, the thing is, this is sort of a continuous process, right from where you diagnose it. So the main thing is, again, this is like a multiple people should be involved. There comes the role. A physician is the most important thing in the thing. But I think over a period of time, since because there are nursing people who are there, these are the most important person who are there in contact with the patient.
Yes.
So probably like a continuous process over a period of time, they need to be made understand about the condition, about the treatment plan, about the goods, about the beds. But again, the thing is, it is not like a one-day process where you tell it and it is over a period of time. You need to make them understand, and I think so. Here comes the role of all the caregivers at the proper role. So yes, and the breaking the news is not a single process. It is for a period of time you make them realize, and all the people, including our nursing staff, are equally important in helping patient cope with this disease and to take a proper decision.
Yes. So when we are looking at these core essential elements, these are the essential elements which has been practiced in palliative care or setup or in the ICU. Like right from management of pain and medications and its symptoms, which is very important, because as we understand that managing pain itself is the first fundamental factor for patient who is undergoing for this distress and all. So, sir, if I talk about advanced care planning, and what does advanced care planning means in this setup, sir, from your point of view?
Uh, how do we define the advanced care is for those patients over a period of time whom we know at the end of the day this is a disease patient who are we don't have much options available in future, probably a few, and the duration of life or probably the future life is short. It is to make patient understand. Here I will put one more emphasis. It is not the patient who is important, but equally important are their attendants. So
Attendant.
they need to realize what is the disease all about, what is the goals of our treatment, what will be the future plan. Secondly, advanced life care is something that we need to understand is as long as patient is able to take his own decision, patient will take. What if the patient has some problem and who will be the other person who will be able to take the decision? Thirdly, important is over a period of time when the patient deteriorates, what is the level of care they expect?
Yes.
Is it the way that we go ahead with the aggressive management, which we probably say not good enough? So the main emphasis of advanced care is to make patient realize or to make them understand and their attendance regarding the disease, the nature, the level of care that is expected in the future, what is the goals of the treatment, and more importantly, to make them understand the barrier. Because this word over a period, if we have not been counseled properly, there's a lot of problems occur. So there has to be a proper communication with the patient and the attendants, making them realize the entire course of the disease, the future course before, so that when the time comes, they will be prepared to take the decision properly.
Yes. So exactly as you said, not only the patient, maybe patient is already on the invasive treatment and sedated, but also, the family members who has to be participated in decision making process. So ma'am, again to you, like when we look at this factor of communication, uh, how do we simplify these communication methods? Like, because this situation
See,
itself is a very complex and lot of conflict may,
correct,
arise.
correct.
So how do we
See,
simplify?
what happens is, when a news like this comes, there is a lot of what we call in REBT language, in emotive behavior therapy, we call it. There are a lot of old traumas that suddenly surface within the family,
Yes,
traumas that are irrelevant to this, right? Or we have things like, why me? This should not happen. How can this happen? These are we have predominantly 7 thought chains that come. We call it thought corridor in psychology,
yes,
which is essentially, this should not happen. What can I do to prevent this? Why is this happening to me? Why me? Is the doctor competent? Is the service that I'm taking competent? Am I missing out on something to make this better?
yes,
Now these are all, what we call in psychology, these are all bargaining, right? Because it's a form of their denial. It's a form of, it's too much to take, it's overwhelming. Because understand that while a patient of course is suffering, and he will be transitioning through care, there will be stages of care from the time the symptom or the diagnosis is made to the time of, if we call it end of life, that is it's a duration. It could be weeks to months to years. So in this there will be stages. Now what happens is, usually we provide counseling at one stage and again at another stage, but the patient and the family require a regular assurance. It is an everyday phenomena. It is almost like, you have to be repeated and repeated and repeated, which is where nurses come in. Because
yes,
it may not be possible for the consultant to every day meet the patient and give that kind of we call it psychoeducation, right? It's
yes,
not possible, but the nurses can do that,
yes,
right? The trained nurses, they can go in and they can talk and they can assure and they can say, hey, you know what, there is still life left. What good can we do with the life that we have? Let's talk about that. And when this is reinforced, repeatedly, then we will come to some sort of a positive stage in care.
yes. And as we were talking, the very crucial essential of comforting this patient is nothing but pain management. And as yesterday, when Sir guided me to have this ladder of pain with Dr. Amarnath as well, as WHO has already described this pain ladder selection criteria, which is very important because here we are going to provide the comfort care in terms of managing and alleviating the patient's pain. So when we have seen this, escalations of pain scale, like as you said, first we need to understand when we are going to, administer the strong opioids. Like nurses at bedside, it is not that they just take the inventory and dilute and then they just start the infusion. So nurses out there, we need to always tell them, you need to look into that when the strong opiates like morphine and fentanyl is given, as you know, that breakthrough pain, when we have something called Wong Baker scale pain, which we assess for the patient. So breakthrough pain, what we are supposed to give, and when the weak opiates and when we titrate this patient's pain scale, what kind of tramadol and tapentol which has come nowadays, which is very safe also, because opiates should be, logically decided not to have the opioid dependency, and simple analgesics when we shift this patient to the ward setup. I think the sir may also agree because we send with a lot of fentanyl patches on and these pain modalities. What is your take on this, sir? Yes.
So
Also,
now, when we talk about what we say palliative care or end of the life care, the most important component, and everybody will agree, will be to control the pain.
yes,
Most of the patient towards the end of the life probably have some sort of a pain, probably what we say bedridden. So there could be pain due to infection, due to bed sore, or due to primary disease.
yes,
So the control of pain will go a long way in relieving the symptoms and more importantly, the basic concept of improving the quality of life. And here comes the role of what we say these analgesics. Now, recent years have seen some relaxation of the rule so that the drug called as morphine, which we commonly use towards the end of the life, are available. equally saying this, we need to understand there are now a variety of analgesics available, and a proper understanding of these analgesics and how do they work, and at what situation will you given what, will help in a long way in helping people get pain control. So again, here comes the role of the nursing staff also. They should know the type of analgesic. Of course, under medical supervision, they will give that analgesic, but they should be familiar in using it, because
Yes.
in end of the life care, these analgesics are equally important. The routes that they give is important. The anticipated side effect once you give this treatment is important. And this is one of the most important component of the treatment, and an important component of what we say palliative care or end of the life care.
So, sir, when you have said this, do you also prescribe morphine at home, like when patient wants to shift to home-based palliative care setup? Do you also prescribe morphine at home in our oral form, sir?
Yeah, morphine is the most important component and probably the best component and one of the strong opioids. So, morphine, yes, we prescribe oral tablet and we decide. So, you start with the lowest possible dose, covering the 24 hours pain control. And as and when you say breakthrough pain, you need to increase our doses. Now, the problem with IV morphine is at present, for my knowledge, IV morphine is something that is used less at home. We give it in hospital under medical care. Now, do we prescribe some form of what we say systemic morphine, not oral? So, what I have is know, and what I had a understanding and I had a discussion with those who take care is we are using subcutaneous morphine. This is something over a period of time we are using it here in Telangana. uh, a small doses over a period of time we increase. So that is, we are using it as a home, as a part of home care. IV morphine still in at least in Telangana we are using IV morphine to a lesser scale. Oral is what we try to shift every patient on. So initially, if the pain is very severe, there is problem in GI, we may start with subcutaneous, but our main aim is to keep the patient on oral medication as long as possible, because probably a slightly safer form, as we consider, without, where you don't require a stringent control, that we give it at home.
Yes. So again, I think, sir, you will also agree that in the our counterpart world, they use a lot of opioids. I mean, and they have a sort of patient-controlled direct infusion analgesic pump, which is there in the form of technology and all. So yes, greatly, as you said, these are all high-risk medications to be diluted properly before administration. We request all the nurses to check before you administer and then only administer, and make sure that you even see these potential side effects of these, like chronic fentanyl use will again land up in constipations and nausea, vomiting, and we may also see patient experiencing respiratory depression sometimes. So we got to monitor these patients in the ICU setup. And madam, again, we would like to also understand from you, is there, as now patient is already on, the sedation and paralytic agents. Is there, like when we were talking about delirium, confusion, and patient is already known that patient is nearing to the impending death. So is there any psychological factor which is, creating pain to the patient? Or patient is
See,
experiencing.
see, this is a very more than a medical question. It is more a spiritual question, because sometimes pain is in the mind. If we
Yes,
don't know, then we don't know,
yes,
right? Of course, this is a very debatable topic for rational people. But having said that, we have seen, there are some CBT techniques that are used in psycho-oncology, especially psycho-oncology, because oncology end of life is very, very painful, especially, right,
yes.
as compared to, let's say, a psychiatric end of life, or let's say a pediatric end of life, right? Even for heart, but mostly for oncology, we have seen that when we teach the patient, right, there are techniques, there are CBT techniques where we can teach the patient to accept their pain. So usually what happens, as human beings, we avoid pain, right? We
Yes.
push it away. When you push it away, you feel its impact more. So there are actually techniques, there are in psycho-oncology, these are researches that have been done, where you can actually teach them to accept pain, and when they are mindful of their pain, the pain actually diffuses. See, the pain doesn't go away. Let us be very clear. We cannot eradicate stuff for we cannot eradicate the distress. We can minimize the distress. So our aim as palliative care specialists will always be to minimize the distress, right? But of course, there are medicines, like sir said, in psychology we don't have too many medicines. We only have techniques which help to diffuse it off, diffuse the pain and such. There is also something called SPPC. Okay, it is of stages of palliative care. This is Santa Clara University, if I'm not their medical council. They had come. There was somebody called Feldman. He came up with this technique, stages. Okay, stages of death, stages of care, and the stages that we can come in. Intervention in stages. So it's a three-way. How should I say? It's a tripartite, as we call it in medical,
Yes,
right?
yes.
It's a tripartite intervention technique which helps, and but of course it needs to work as a team, and this is given not just to the patient but to the entire environment. In psychology, we call environment of patient as the immediate stakeholders who are involved, the people who are involved in the pain, right?
So
So
now, yes. So now we are having discussed the emotional factors and pain management. Now, when we look at these different advanced, directions or directives, whether still or till date, the controversies among comfort care or aggressive treatment. Let's say a real anecdote says one patient wishes just to withdraw all the active resuscitative measures, but the attender says no, we like to prolong. So this leaving will, when they, there is a challenge between receive or refuse. And again, the concept of DNR and DNI or deferred treatment or such a scenario, sir, is DNR, DNI advanced directives continue to pose challenges? I'm sure yet, but in short, yes.
Very much so. That is where what the previous question was, advanced planning comes.
Yes.
This is a continuous communication process. For those patients whom we know the time limit is less, or this is something which is progressing at the fast rate, this thing has to be discussed beforehand only. And if the problem comes is when this discussion is when the patient has already deteriorated, the patient's attenders may not be aware of the gravity of the situation, and they may refuse to accept first and take a decision properly.
Yes.
So all these things we need to remember is this has to be discussed beforehand before the patient's condition really deteriorates. For us, we always encourage that the patient should not go ahead with the aggressive treatment when he is in the terminal phase of the disease. The other problem, which is practical, which I have seen is, which is probably out of context, is the attenders stay abroad. So,
Yes.
so most of the time, what happens by the time there are senior citizens who are staying alone here. So the children has to get back to India, and if they deteriorate, the problem comes is they want them to live for 4 5 days more so that they can all those things. And there comes the most difficult part is should we intubate, should we not intubate? Because we
Yes.
know that entirely futile thing. But for a city like Telangana, this is the most relevant thing. 3 of the 10 times we have to do it because we want them to survive, because attendants have to come from abroad, and that is something beyond our control. But saying this, the most important thing is there has to be a proper communication, and most important, sisters are involved in this communication because
Yes.
they are the person who are there with the patient. That suppose if there is a deterioration, do they wish to go ahead with the aggressive treatment, which is futile? So a proper communication regarding the end of the thing, what will be the thing, and whether they will wish to take it on an aggressive course, because it is not going to improve the quality of life. So for us, yes, a communication, a beforehand advanced planning, so that these things, these issues should not come towards the end. And that is the most important part of thing is, again and again, I stress this, a proper discussion with the attendants. Also, equally important here to make them understand about the disease, the goals of care, uh, and probably towards the end, these are the things will happen. And it is always good to make them uh, have a comfortable life rather than in among those things which we probably may prolong suffering without improving the life.
So, ma'am, again, as rightly sir said, and we do have the best practices of, doing AV counseling, audiovisual counseling, and documentation every day, and if required, every 6 hourly, 8 hourly as well, to avoid the legal implications and other factors. So, such challengeable scenario when nurses are working, how should they support their emotional well-being? Because nurses are all within their 25 years of age. They may not understand this fear or kind of complex situation which is arise. So how do they support? What should they do? Because this end of life patients are there for a lot of days. They are in the ICU. So should they do?
So first of all, we have to understand and we have to respect this as a high distress job. Just like we would respect any other job which is let's say a jet pilot or anybody who has a high stress job. We have to understand that this is a high distress job, so that particular nurse cannot be working for 18 hours, right? So which is where I think some sort of process and procedures relevant to palliative care needs to be slightly different. The module needs to be slightly different in terms of the duty, the person who is doing the duty. Now if let's say a certain nurse has just lost a family member in recent times, when
Yes.
she is put into palliative care duty, obviously her pain is also vulnerable, right? And she's very vulnerable, and as you rightly said, Shanti, these are all young girls, young girls and young boys too nowadays. So
Yes.
these people, their own palpable pain going to the patient's pain coming back, it is not a very healthy situation. So we need to have, we call it armoring in psychology. The
Yes.
person who's going needs to be armored, that okay, now I am, see, even after all these years of work, if I go into, like sir knows, when I go to see sir's patients or I'm going into the psycho-oncology ward, I will go with a certain mindset, right? I have to go with a certain mindset which
Yes.
is very different from seeing another patient. So
Yes.
first of all, we need to specialize training,
Yes.
right? We need to prepare them. They are our soldiers. They are our soldiers who are going to go and heal the pain. So I think that is where that training needs to be there. A little bit of psychological training also for the nurses, maybe, right? Um,
So that's how I think we have started the palliative training now. The set of management of EOL in the PC setup already just started in Secunderabad unit, and we'll see the progress out of it. And now, when we look at the managing of these distressing symptoms from the patients, and the nurses' roles are very crucial. And I think, sir, whenever the patients are in the ward, so we also would like to tell here all the nurses that these are likely, changes of the, changes or the symptoms which patient is now, giving. So should the nurse be not to become panic, and she should not, she should always escalate to the doctor and not to shift the patient in a hurry to shift the patient. What do you say, sir, about this?
Perfect. What you said is the most important thing I always say is not, it is not the treating doctor, but the nurses which are there, because the maximum time that the person, health professional, that spends with the patients are nurses. So
Yes.
probably their proper training will go a long way in helping patients get treated or understand the symptoms and their solution. So it is all the nurses which are most important in these all in the management of this patient, because they are the person who will always be in touch with the patient, and their proper communication with the patient may go a long way in helping us relieve the suffering that the patient have towards the end of the day.
Yes. So we have come to the end of the discussion, which is again our conclusion. Is there a need for greater integration of palliative care into the broader aspects for end-of-life patients? As you said, we have still a lot of journey to be embarked on, and high quality end-of-life care that aligns with their preferences and needs, which we always focus on. So, ma'am, again, the last question to you, that how these challenges to be navigated effectively.
Which challenges, ma'am?
The healthcare professionals, when they have these challenges when they are bedside.
Right. So, we have something called a befriending technique. Let's say people who are working in, you're very near the door of death. We call it the door of death. And when you're helping someone take that journey, you have to come back and get some sort of distressing of your own pain, right? You have to come back and somewhere start maybe let go of that burden, right? You talk to another colleague, because we always feel what more we could do, especially those of us who are sincere workers. We keep feeling, what more, and we keep pushing ourselves. So somewhere, and we don't want to put that boundary where we want to stop ourselves. So at that point, I think it is very important to have a team, to have a diffusing agent, right? A member of the team, where after you've done your work, you come back and you say, hey, you know what, this has happened. You diffuse it and you go. Otherwise, you will carry it into your personal life, you will carry it into your homes,
Yeah, you ventilate
right?
out
Which is
all
not
that.
required, because
Yes.
you have to do this again tomorrow. So
Yes.
it's very important, it's like the pressure cooker whistle. We have to let out the steam here and go, so that we can effectively see another patient tomorrow,
Yes.
right? I think that is very important. There is a in UK we have a system called befriending, right, where the person who does this kind of near death or anything which is of such serious intensity, you have to it is your duty, before you sign out, you have to distress yourself and go,
I think, yes,
right?
that communication is always important to ventilate out. And yes. So thank you. As very, this topic cannot be just finished within half an hour. And I thank Dr. Bharatji and Madam, क्योंकि आप लोग busy थे फिर भी आपने contribute किया. Thank you so much. And to all the nurses out there, whoever watching this webinar, we cannot change the, outcome of the patient, but we can affect the journey of these patients. So I urge and to all the nurses, please provide comfort care with empathy, keeping the empathy mind in nature. Yes. Thank you. We end the session. Thank you, sir.
Thank you, everyone. Thank you.